Students, I am going to talk about ED care and trauma. So in emergency department care, they care for a lot of different people, cradle to grave, um, people without insurance, people with insurance. Most of the conditions that the nurses are going to see are acute or critical care conditions. Okay, it's not primary care like the media will lead you to believe. So ED nursing is episodic and chaotic. So episodic care means, somebody comes in, they get seen, they get the basic treatment, and then they go to where they need to go. And it's really important that they go there as quick as possible, because research shows us when they stay in the ED for a long time, it's not good. They need to go to, like, if they need to go to critical care, they need to get to the ICU as quickly as possible, okay? Because that's where they're going to get the care. The ED nurse is going to get them stable and get them to where they need to go, okay? So most of the care provided, again, is critical and acute care. It's cradle to grave. ED nurses have to be very knowledgeable about assessment of all age groups, okay? So they need a wide breadth of knowledge. And they function under clearly defined medical protocols, because many patients, when they come in, they don't have their medical diagnosis, right? So, like, for example, MI comes in. Well, it's not an MI yet, right? Somebody with chest pain comes in, and so the nurse has medical protocols they can follow, like get the EKG within 10 minutes. So it's kind of like standing orders, and I know we don't like to use that word anymore, but that's really what it is. So that's why ED nurses need excellent assessment skills. The ED triages the patients as they come. There's no one universal triage system that everybody's using, but the most common is the emergent, urgent, and non-urgent system. Okay, so the triage means to sort. So the nurse working triage has to kind of sort the patients and put them in a category. So emergent refers to life-threatening conditions such as respiratory distress, chest pain with diaphoresis, ripping, chest pain. That's probably a dissecting aorta. So that is a medical emergency. Pale, cool, clammy skin. So those are some examples of emergent conditions that would need care right away. And then urgent means quick treatment, so a couple hours probably. Severe abdominal pain, renal colic. Renal colic is really painful. And, multiple fractures, open fracture. Older adults that come in with a new respiratory infection and have a temperature, they would probably need to be seen urgently. And then with non-urgent, these are your people that get upset for being in the waiting room the longest because they're non-urgent. And you might have to do a little education as the triage nurse. So these are things like skin rashes and strains and sprains. Okay, now I want you to keep in mind that students in exams are getting urgent and emergent mixed up. Okay, so I just remember, if you're asked who's urgent, it's people in this category, not people in the emergent category. Okay, so emergent is an emergency. So that's the way I kind of think about it. Now, what steps should the nurse take if you get a patient that has mental status changes in the ED or anywhere? Okay, we've talked about this before in some of the case studies. First, you're going to assess the LOC and compare it to the baseline. The brain runs on sugar and oxygen. So you're going to check the O2 sat and the blood sugar, because those are easy fixes. If they're hypoxemic or if they have a low blood sugar, you can fix that quickly. Take the vital signs, check electrolytes, maybe ammonia if you think it's indicated, and get to the bottom of it. Get to the bottom of why they've had mental status changes. Okay, we're going to talk about chest trauma. And with chest trauma, there are a couple of conditions, the pulmonary contusion. The big thing with that is the chest x-ray is not even going to show anything for 48 hours. So they may need, so anyways, what I'm trying to say is it's like a bruise. When you you hit your leg on something and then the bruise doesn't get really big until a couple days later. It's kind of the same thing, okay? So what I'm trying to say is you have to watch the patient for a couple of days to see what it's going to be like. And then the fractured ribs. The big thing with the fractured ribs is that it can, if they're up high, it can, injure the great vessels. But if it's down low in the ribs, it can injure the organs. So if somebody's complaining of left-sided shoulder pain, think Kerr's sign on the left, and that um, indicates splenic rupture. And then on the right, it could indicate pain in the shoulder is a positive Kerr sign, and it could indicate that the patient has a liver laceration and they're bleeding. All right. Now, for the last exam, I taught you about a paradoxal pulse. Well, now I'm going to teach you about paradoxal chest movements. So paradoxal pulse means cardiac tamponade. Paradoxal chest movements means flail chest. Now, flail chest happens when there's a little flail segment in the rib cage. So how that happens is in trauma, you can see here like the rib, this little segment is broken on both sides. So it's free floating, okay? And it's gonna go the opposite of your breathing. Okay, so it's called paradoxal chest movements or paradoxal respirations. Think flail chest. Okay, now basically, these kind of conditions are all going to be treated, depending on how the patient presents, the severity of the injury, right? So it's going to be symptomatic. All right, so you would expect hypoxemia in really traumatic conditions, in respiratory acidosis. So the reason that they have respiratory acidosis with chest trauma is because it's painful and they don't want to breathe, even despite with hypoxemia. Remember, I told you it sends a message to the brain to start breathing faster and deeper. Well, they're doing the faster part, but they can't do the deeper part because it really hurts, okay? So your job is to medicate them enough so that they can engage in deep breathing, okay? Now, anybody with bleeding obviously could have hypovolemic shock, and you're going to see shock-like vital signs. Okay, so the treatment of chest trauma is going to be symptomatic depending on what they present with. They could need positive pressure ventilation. They could just need O2. They could need mechanical ventilation. With pain management, this is important because this is going to help them breathe better and be more comfortable. So you can rotate your ketorolac, which is an NSAID, and then in morphine. And then this intercostal nerve block is fabulous. When I worked in the PACU, we had an acute pain system, and all our total joints, all our thoracic surgery, when this came on board and patients started getting blocks before surgery, oh my God, it was amazing because they don't feel anything and they can move around and breathe. So that was really good. Now, you want everybody to use a sensitive spirometer. You want them to turn, cough, deep, breathe. But again, you have to medicate them. Suction if needed, but never on a schedule. And you're going to position the same as respiratory failure, so good lung down, because when you put the good lung down, it helps with perfusion. The lungs are going to be better perfused that way. Okay, now we're going to talk about pneumothorax, tension pneumothorax, and hemothorax. So a pneumothorax is when air gets into the pleural space. And this happens during medical procedures, like we talked about pacemakers, central lines. We talked about a liver biopsy. During the procedure, you have the patient hold their breath, exhale and hold their breath for 10 seconds so the provider doesn't inadvertently give them a pneumothorax. Tall, skinny kids can just get one, like spontaneously. COPDers can get spontaneous pneumothorax. So pneumothorax can happen for many reasons. Attention pneumothorax usually happens due to trauma. So what happens is there's a wound, and air can get in to the pleural space, but it can't get out. So if you look at this picture here with the blue arrows, that is your tension pneumothorax. And if you look at the red arrows, okay, this is all the organs or great vessels getting pushed to the side. Now the sign you'll see is tracheal deviation to the unaffected side. Okay, so it gets pushed to the other side. So that's how I remember that. They're going to need immediate needle decompression. Your job is going to be to find the biggest needle you can to help with that. and then they may have a chest tube inserted to drain that air. Okay, hemothorax can happen in trauma. May happen after a thoracentesis, and that's blood in the pleural space. Okay, so in any event, any one of these conditions, the patient can end up with a chest tube. If the tube is, and they can also have both, like they could have two chest tubes connected to a wide drainage. Okay, that's what my thoracic patients, when they had surgery, came out with. So the top, a chest tube placed in the top, or I should say in the upper, near the upper lungs, is to drain air, and that should make sense because air rises. And if it's placed lower in the pleura, then that's to drain fluid or blood, like after surgery. Okay, so that should make sense. We talked about thoracentesis a little bit for prior to exam 1, but I just want to remind you that anybody with either thoracentesis or a chest tube, they're gonna have pleuritic chest pain. Okay, so that's pain when breathing. I'm not worried about it because I expect it and I'm just going to medicate it. Okay, so it's not something I would worry about. Some of the signs and symptoms of pneumos, hemothorax, or tension pneumothorax include the pleuritic chest pain, so you're going to expect that. They may have JVD, depending on how big it is. They may have a tracheal deviation, like with a tension pneumothorax. It's going to be sudden, the symptoms. No, you won't hear any breath sounds. So that makes sense, right? Because although there's air in this pleural space, this air is not moving. Like when you listen to lung sounds, the air is moving through the lungs. There's no movement there. Same with here, right? Same with here. You're not going to be able to hear lung sounds in that area. Okay? So look for dyspnea, look for those shock-like vital signs, and then remember the deviation to the unaffected side. I made a series of videos. You can watch that if you need to go into, you feel like you need more in depth. I go over the chest tubes really well and the 3-chamber system. When I was in nursing school, the first time they went over that 3-chamber system, I just went home and cried. I thought I was going to have to drop out of nursing school. I was a junior in nursing school. I remember it. It was awful. And we didn't have computers back then. So the instructor wrote it on the board. It was terrible. Anyway, so I'm going to go over the chest tubes now. Don't get a chest tube confused with the chest tube drainage unit, because we kind of like talk about them interchangeably, right? But they're kind of two different things that we have to talk about. So with chest tubes, okay, it's a 3-chamber system. Whether it's wet or whether it's dry, it's all built on the same principle. And this first chamber is going to be the drainage chamber, a fluid collection chamber. And this right here goes to your patient. Okay. And the blood, the fluid, if like somebody had surgery, would flow into here, and then it rolls over to the next chamber, and then it rolls over to the next chamber. And you mark it beginning of your shift, end of your shift, and you do the I&O. And I can show you how to do that in class. Okay. The second chamber is called the water seal chamber. And with the water seal chamber, this allows, if you look at these arrows, it allows the air to go out, okay, goes underwater, comes out, and it's able to go out into, out of the lungs, okay? But it can't come back in because there's water here, okay? So it allows for the one way of air to get out. Okay, so the water seal chamber is filled to 2 centimeters of water, and you should not see constant bubbling in the water seal chamber. If somebody has a pneumothorax, it is an expected finding for them to have intermittent bubbles when they're breathing out, okay, or they cough, but it's intermittent. It's not constant bubbling, okay? That's important for you to know, because you have to know where the bubbles are and where the bubbles aren't. Okay, now in the water seal chamber, you're going to see the water tidling or moving or oscillating, and that's how it's described, when the patient breathes, and you should see that. Now, if it stops moving or stops tidling, one of 2 things have happened. there's either a kink somewhere in your system, okay, or or like the drainage tube became dependent, okay, or you have a clot or something, or if it's for pneumothorax, it could mean a good thing, right? It could mean that the lung has re-expanded and now there's no more air to escape. Okay, so it could be one or two things. And then with the suction control chamber, this is, you fill the water to negative 20 centimeters. I don't know why it's called that, because it exerts negative 20 centimeters of water, but it's always, every time I have to do one of these, it's always at negative 20 centimeters. There's going to be bubbling in this system. And because the reason it's bubbling is because you hook it up to wall suction, okay? And this helps remove air from the pleural space, but you don't put this so the bubbling is roaring, okay? It's just gentle bubbling, because if you put it up too high, all it's going to do is evaporate the water, and you have to keep filling it up to 20 centimeters. Okay, now there are some must-haves that you must have in the room. The first thing is you need padded Kelly clamps or padded hemostats. Okay, you need sterile water, sterile cup, and sterile dressing supplies. You don't need to have another chest tube drainage system. Okay, now if the chest tube comes out of the chest, okay, the whole thing comes out. The patient sits up, pulls on it, comes out. Okay, you are going to stay with your patient. You're going to take one of these, you're going to call a rapid. Okay, you're going to take one of these dressings, tape it on 3 sides, and that is to prevent a tension pneumothorax so air can escape. You wait for people to come. You never leave your patient. Okay, see how they do, because that's what you're watching for, a pneumohemothorax. So attention pneumothorax. Okay, and then what you do, say the chest tube is still in the chest, but it comes dislodged from the drainage, chest drainage unit. Okay, you're going to take the chest tube and put it under sterile water. Okay, that's what you're going to do with that. That's why you need to keep sterile water in a cup in your room. Okay. Now, with chest tubes, when to call your rapid or the provider, always stay with your patient. If you think they have a tension pneumothorax, again, stay with your patient. If you see islets, these are islets. Islets should be inside the pleural cavity, not outside. So you do not want to see islets when you're doing your dressing changes. If the O2 stat is less than 90%, you would call your rapid. If the drainage is over 70 for a pleural, or 150 for a mediastinal tube per hour. Okay, sudden shortness of breath, you would call a rapid, definitely. If your patient develops subcutaneous emphysema, so subcutaneous emphysema may be expected, but if it's a new symptom, you need to let the provider know. It means like air is escaping through the skin. It feels like Rice Krispies under the skin, okay? Now, if somebody has it around the chest tube because you feel for it, right, and it's new, you would need to notify the provider. If somebody has subcutaneous emphysema in their neck, they need to be intubated, okay? Especially, after trauma, that can happen. And so here's a picture of the 3-sided occlusive dressing. If it gets dislodged from the chest wall, you put it in, and if it gets dislodged from the drainage system, you put it in an inch of sterile water. Okay, and these are more videos for you. Okay, so if you're going to help the provider DC the tube or remove the tube, okay, remember you want to give IV medication, narcotic medication 30 minutes before. POs 60 minutes before. So as soon as you see the provider on the unit, you got to skedaddle and get them medicated, because they're not waiting for that to kick in, right? When it's pulled out, you're going to ask the patient to bear down, exhale, and hold their breath. You're going to put petroleum gauze jelly over the hole when they take it out, and you're going to monitor for pneumothorax. They'll do a chest x-ray after to make sure that didn't happen. Okay, so that's your role in a chest tube removal. And then when patients go home after they have this incident, they need to call the provider if they have like an infection, if they have fever, cough, or difficulty breathing. Um, sharp chest pain, okay? Because remember, pleuritic chest pain is expected when somebody has had a chest tube. Um, and that's chest tube. I'm going to go over environmental, um, some environmental conditions you might see in the ED. So the first thing we're going to talk about heat-related injuries and cold-related injuries. And I have some bad news. You can't drink alcohol or caffeine with either of them, okay? Because that puts you more at risk, okay? So for heat and also cold, you need to wear sunscreen when you're out in the sun, SPF of 30, okay? With heat, you want to make sure you're resting frequently, limit your activity during the hottest part of the day. You don't want to go for a run at noon when it's hot and humid out, and take cool baths or showers to reduce your body temp. Now, whether it's a heat injury, related injury you're preventing, or a cold related injury you're trying to prevent, you need to wear sunglasses, hot or cold, to protect your eyes from the UV rays, okay? With cold related injuries, you want to wear synthetic clothing, so no cotton. You can't wear too many socks either because it can decrease your circulation, which is what I love to do when I'm out in the real cold, right? I love to wear like a couple pairs of socks, but you can get frostbite that way. You want to layer your clothing, and the outer layer needs to be windproof, okay? You want to wear a hat at all times and a face mask if needed. Even if you're exercising, you leave a hat on because that's where most of your heat um, escapes. Okay, and then teach people to keep extra water and clothing and food in their car. Let me tell you, I lived in Georgia and there was this one ice storm. I lived like 7 minutes from the hospital I worked in, right? It took me 5 hours to get home. First of all, people in the South don't know how to drive. But in addition to that, um, we were just stuck in traffic. Nobody could get anywhere. It was awful. So it's good if you're in a winter climate to keep things in the car in case you do get stuck. And also, like, you might keep an empty bottle in the car as well in case, for males, if they have to urinate or something, that's like a good option. So know your personal limits. Don't go outside if you know it's too cold for you, okay? All right. So you need to be able to differentiate between heat exhaustion and heat stroke. All right. So with heat exhaustion, it is just like dehydration, okay? They're going to have like flu-like symptoms, okay? They may have a headache, but they're not going to be confused, okay? And that's an important distinction because with heat stroke, people they get bat crap crazy, okay? So they get really bizarre. They can have seizures and coma with the heat stroke, not with heat exhaustion. So that's a differentiating factor, okay? So with heat exhaustion, they'll have a weak pulse and tachycardia, nausea and vomiting, and they're not going to have a temperature, okay, like they do in heat stroke. So the interventions are stop what you're doing and go to a cool place, drink some fluids, right? And then with the heat stroke, they have a temp greater than 40 degrees Celsius, 104. I mean, it's just crazy. They have shock-like vital signs. The skin is going to be hot and dry. They may not perspire. Like in heat exhaustion, they have profuse sweating, whereas in heat stroke, they do not. They're going to have mental status changes in heat stroke. That is the defining characteristic, one of the defining characteristics, okay? So if somebody has mental status changes, they have heat stroke. They're going to develop oliguria, coagulopathy, and pulmonary edema. So the treatment is to give high O2, cooling them off with IV fluids. Also with you can put ice packs to the groin and axilla and give ice, gastric, and bladder lavage. Okay, so that's the point there. You keep them NPO and do not administer antipyretics. Okay, so they'll get cooled off by the cooling techniques. Okay, now I'm just going to talk a little bit about lightning, just a few things I'm going to touch on because We're going to go, you'll learn about like kidney disease in the next unit. Okay, so I'm going to just do a light thing on this. Okay, so with lightning, okay, you can do CPR on a patient that's had a lightning injury because the electricity is not going to travel to you. So you're going to provide the normal care, ACLS care. So the thing about lightning, they can have brain bleeds from it, so they need to have a CAT scan, but they can also have dysrhythmias because it could affect the electricity of the heart. So you need an EKG. They're going to have elevated CKs because myoglobin is going to leak out of their muscle tissue, and it's going to cause rhabdomyolysis, which causes a kidney injury. So you're going to see, all you need to really know is tea-colored urine right now could be a factor in that. The most important thing is the heart and the head. Okay, so we're going to talk about hypothermia. You don't need to know which temperatures are going to cause either moderate or severe, but you do need to know some of the treatments, because the treatment is going to be different. Okay, so with moderate, okay, these people will be confused, they'll be stuporous. Okay, so I kind of think of this as like a little drunk, right? They could have apathy. And then how you treat this is with core rewarming methods. So you don't want to put warm blankets on their limbs. You don't want to warm the limbs first. You want to warm the core, because as the blood circulates, it should circulate the limbs, the warm blood. Okay, so this is through moderate is through IV fluids, warm IV fluids, heated O2, heated peritoneal, pleural, gastric, or bladder lavage. So you're warming the core, but it's from IV fluid. It's from like inserting fluid inside the body. Okay. With severe hypothermia, your patient can go into VFib and asystole just by touching them, so you have to be very careful. But this is so severe, you need to take the blood outside the body to warm it. Okay, severe, you take the blood outside to warm it. It's extracorporeal rewarming. So there's two options that can do that: dialysis and a cardiopulmonary bypass machine. Okay, so you never want to put like heating pads on somebody or a warming blanket to warm somebody up. You want to warm the core first, okay? Now, frostbite is an actual burn, okay? And we're going to talk about burns at the end of the semester. I'm just going to tell you a few things right now. Now, the treatment of frostbite is to rewarm. Extremely painful. You have to give IV opioids. Do not give them IM, okay? And I don't really think anybody gives them IM anymore. You want to do IV rehydration. You're going to give ibuprofen around the clock, not PRN, to decrease the inflammation. Never massage or use dry heat. Assess your neurovascular status and look out for compartment syndrome. And I know you know what compartment syndrome is. You had a med-surg 1. They will need a tetanus shot. In fact, most of the bites and things like frostbite are going to need a tetanus shot, and we do that for people that haven't had one in 10 years. Okay, so, and then I'm going to talk about snake bites really quickly. So with snake bites, I'm only going to talk about two different kinds because they're most common in the United States. So the coral snake. The coral snake is a really pretty red, black, and yellow snake, okay? So the coral snake is going to affect the cranial nerves, and they both begin with C, so that should be easy for you. Okay, so you're going to see descending paralysis or descending cranial nerve deficits. Okay, so look for weakness, change in LOC, drooping eyelids, double vision. Okay, that's what you're going to see in somebody with a coral snake bite. Okay, you're going to monitor for the elevation of the CK levels. They'll probably go to the ICU. We don't have any venom, so it's just going to be supportive care. Okay, so they may need to be intubated because of the descending paralysis. Now, coral snake bites, you're not going to see probably a bite because they have tiny teeth, or fangs, I should say. But just remember, coral snake is cranial nerves. It's going to affect the nervous system. It's neurotoxic. With a pit viper, that's your rattlesnakes, your copperheads, your cottonmouths. It's hemotoxic. So look for your shock-like vital signs. That's the key if it's a pit viper snake, okay? Because you're going to be asked to distinguish, which kind of snake you think they got bit by. So you have to know coral snake is cranial nerves or coral snake is neurotoxic, and pit viper is hemotoxic. So they do have big fangs, and so you're going to see vesicles or hemorrhagic bullae around the area they got bit. Okay, no, you're going to just treat them, symptomatically. So they'll no NSAIDs, but they're going to need to be medicated. And then so the antivenom is called Crofab, so you don't give it to them if they're allergic to pineapple or papaya. So then you would treat symptomatically. Okay. Now, the coral snake mimics a lot of other snakes. Okay. So the top one here in this picture is a coral snake. Red on yellow, kiss a fellow. Red on black is a friendly jack. So this is a king snake, and this is not a poisonous snake. But if patients tell you it's red, yellow, and black, you're going to treat it like a coral snake bite. Okay. If I'm going to talk about bees really quickly. You never want to swap bees. Okay. The signs and symptoms, if they have an allergy or anaphylaxis, hopefully they have their EpiPen with them. You would remove the stinger and apply an ice pack before they come to the hospital. And then you want to maintain a patent airway. And then if anybody gets bit on the hand, whether it's a snake bite, a spider bite, bee bite, make sure you remove all their jewelry because they're going to swell later and you're not going to be able to get it off, okay? And that's a priority because that can cut off their circulation, okay? And the wasps are the same as bees, and that does it for this